Hello, my name is Rich Bassett. Today we're going to be talking about mechanical ventilation in the transport environment. I'm a paramedic, flight paramedic here at Lehigh Valley MedEvac. Just to review our objectives, we're going to talk about the breath types used in mechanical ventilation, review of ventilator modes used in the transport environment, strategy for changing ventilator settings when needed, and a brief review of the LTV 1200 and the Hamilton T1 transport ventilators, and some resources for a more comprehensive review of each. When we talk about breath selection, we're really talking about volume or pressure control for the desired breath type. Most often, especially with the adult population, we're going to use a volume. So I think most of you would be familiar, we set a volume around anywhere 400 or 500, 600 milliliters per breath. When we talk about pressure control ventilation, that's actually when we set the ventilator to a pressure that's going to ventilate up to, like let's say 20 or 25 centimeters of water pressure, and then the ventilator is going to stop delivering that breath. Typically we use the volume ventilation for most adult ventilation, and sometimes we use it for the adult ventilation when we're having difficulty with the volume ventilation, and especially with the LTV 1200 ventilator, we tend to use pressure control for the small kids and the infants. When the volume breath is selected, as we mentioned, the ventilator is going to try to deliver that set volume, the volume that's set by the operator. The only thing that might limit it might be like a high pressure alarm, or actually on the T1 ventilator, if you get within 10 centimeters of the water pressure of your high pressure alarm, it's actually going to start limiting the breath some. Something you need to kind of keep in mind when you're using the Hamilton T1. When we're using the volume ventilation, it's usually easier to maintain like your same CO2 levels, whether you're getting them by blood gas or from your capnography. And when you're doing this, you got to remember you got to monitor your airway pressures for any changes, which means there might be some changes with your patient. When we use the pressure controlled breath, the machine will deliver the breath, as we mentioned, to the selected pressure that's set by the operator, whoever's operating the ventilator. It's often used for smaller children and infants, especially with the LTV 1200 ventilator. As far as the T1, the Hamilton T1 ventilator, that ventilator can actually go down pretty low using volume ventilation even for infants. That's one of the differences between those two transport ventilators. You'll hear me mention that again a couple times today. When you're using pressure control ventilation, especially with the adults, it can be harder to maintain a consistent CO2 level, whether you're doing it through your capnography or through your blood gases. That's because your volumes are going to be changing fairly frequently, even breath to breath. So sometimes it's a little bit more of a challenge to maintain a consistent end tidal CO2, for example. There are times where we might use pressure control ventilation with the adult population. That's especially true if we're having difficulties maintaining our volumes and not wanting to raise our pressures too high, or our pressure alarms too high. Sometimes with a pressure control breath, you can get the same amount of volume or even more volume at less pressure. And the reason for that is because when most ventilators, when they deliver a pressure control breath, it's in a decelerating pattern, and you're able to get more volume in with the same amount of pressure. If you are going to switch, if you decide to switch to a pressure control, the easiest way you can do it is go to what your high, what your inspiratory pressures are, your peak inspiratory pressures, and maybe start just a little bit lower or right about there for your pressure control, and then you'll just have to monitor your tidal volumes to see what you're actually delivering. Whenever you make a switch like that, though, you need to remember to keep an eye on your patient. Their saturations might change, their end tidal CO2 might change, their hemodynamics might even change. There might be change in blood pressure one way or the other when you're switching the type of breaths you're delivering. Just something to keep in mind. The modes. The two most basic modes for mechanical ventilation, especially in our environment, are the assist control, or the AC, and it's also known as controlled mandatory ventilation on the T1 or some of the newer ventilators, or CMV. So when you hear the term assist control in CMV, for us that's pretty much the same. And then there's the SIMV, or the synchronized intermittent mandatory ventilation. At the very least, both modes will deliver a minimum minute volume, and the way it gets to minute volume is your set volume, mainly for your tidal volume, times your rate. So like on the slide here, it has, we have a tidal volume of 500 selected on the ventilator, and this could be either an assist control or SIMV, and then times the rate of 12 will give you 6,000 milliliters per minute of minute ventilation. And both these modes will allow for additional volume based on the patient's ventilatory needs and also the metabolic needs. But the patient also needs to have the ability to initiate spontaneous breaths. And what do I mean by that? Well, if the patient's so obtunded or maybe they're chemically paralyzed, they're not going to be able to initiate any breaths on their own. So the patient needs to be able to at least trigger the machine if they need extra breaths besides the ones that you have set on the machine yourself. A little bit about assist control or the CMV. Each breath, in addition to the set rate of breaths, which is initiated by the patient, will be the same tidal volume. Now, if the patient's in the pressure control breath type, then it'll go up to that same pressure. It'll deliver that same amount of pressure for each breath that the patient initiates on their own. So that means if we have, let's say, a rate of 10 set on the machine, but the total rate per minute that's going on is maybe 15, the patient's taking an extra 5 breaths. For each of those 5 breaths, they're going to get that pre-selected tidal volume, no matter what. So when they initiate that breath, they're going to get that pre-selected tidal volume. And that's going to be one of the big changes, or the big differences between the assist control and the SIMV. For the SIMV, when the patient takes that extra breath, they're only going to get in what they want. It may actually be less, which is often the case, than the pre-selected tidal volume. And then sometimes it might actually be more if they're pretty awake or if they're taking a big breath on their own. Now, along with that, to help the patient from getting tired or to kind of assist them, for those patient trigger breaths in the SIMV mode, we usually turn on some pressure support. And this will help give them a little bit of a boost when they take in the breath on their own. So the big difference between the SIMV and the assist control modes is the assist control, just one more time, they're going to get that full preset tidal volume or pressure, and the SIMV, the patient's going to get really pretty much what they want on it. They might have to work a little more for it, but they're only going to get what they want for those extra breaths. And for the SIMV, the same goes for the pressure control. If they're in a pressure control breath type during SIMV mode of ventilation, then it's going to go up just to that level of pressure that you have set. Now, pressure support, as I mentioned, is almost always used for the patients being ventilated in the SIMV mode. On the LTV 1200, it actually defaults to 10 centimeters of water pressure, and on the T1, it usually defaults, at least the way we have it set, to 15 centimeters of water pressure. And that pressure kicks in again just on those extra breaths that the patient wants to take or needs to take on their own. For you folks that might be a little bit more technical minded, the pressure support really helps in overcoming airway resistance. Initially came out about 20 some years ago. It had to overcome airway resistance, like maybe somebody you're trying to wean that has a COPD history, or maybe their tube's a little bit on the small size. But over the years, it's kind of evolved to help the patients in the SIMV mode almost all the time. It just helps overcome some of that airway resistance. So now the big question is, which is better? Assist control, or also known as the CMV, or the SIMV, or the synchronized intermittent mandatory ventilation. They both have their pros and cons. Some people might argue that SIMV might be better tolerated by the patient who's somewhat awake, It gives the patient more of an ability to determine how big of a breath they want to take on their own, especially when they're more awake. On the other hand, if you have the patient that's really struggling, they need every last bit of oxygen they can get, maybe they're very tired, maybe they wore out a lot of muscle in their chest wall, maybe a CMV or an assist control might be better because they won't have to work as hard when they are taking those extra breaths on their own. They'll get more bang for the buck each time they take an extra breath. Also, if there's an acid-base problem, they might be better off with the bigger volumes. We can talk a little bit about that more later when we get into the strategy for making ventilator changes. Some of the less conventional modes, the ASV, the adaptive support ventilation. This is like a proprietary branded mode by the Hamilton ventilation folks. So you won't see this on the LTV 1200, but you'll see this on the Hamilton T1 transport ventilators and also a lot of the other ventilators at the Hamilton folks market. The whole idea by this is you can set the patient's ideal body weight by setting their height on the machine and set their predicted minute volume, and the machine will figure out exactly how much tidal volume to give, what type of ventilation rate, the flow rates, the whole thing. And what the machine promotes, or I'm sorry, what the Hamilton folks promote it as, it's a way that's, somebody's operating a ventilator, that it's an easy way to set up the ventilator and let the machine do the figuring out what's best for the patient. Speaking to the respiratory therapist here at Lehigh, so far at least, they mostly use it kind of as a weaning tool or a pre-weaning tool, or for some of the more long-term ventilator patients that they just can't seem to get off, like the ones that they are only setting pressure, inspiratory pressure, and CPAP pressures for. Maybe they go to this ASV mode for their long-term patients, or as, like I mentioned, as a weaning tool. It's not really a starting point for us in the transport environment when we're transporting these patients in the acute phase. Now, there are some patients that we do pick up that are already on it, the ones that are going to back to the nursing homes designed for the ventilator patients, or the LTAC units. Some of those return inter-facility transfers of the ventilated patients. Some of them are on this mode, and I would think it's be perfectly appropriate to maintain that. A little bit more about the ASV, just so you're familiar with it. If you do get these patients with it, they base their settings, on the patient's sex, the height, which gives you your ideal body weight, which the machine figures out. And then the big thing with the ASV mode is you're looking for your desired percentage of predicted minute volume. So if we're picking up a patient from the ICU and it's going back to the LTAC unit, for example, they're already going to be set on a range. The machine can actually go from 50% of their predicted tidal volume for their ideal body weight all the way up to 350%. A lot of them are like 75, 100% of their predicted. The patients can take more if they want to. As far as, maybe changing that range, talking to respiratory folks here, when we are transporting these patients, sometimes the patients get a little anxious, and you'll turn up the percentage maybe a little bit, maybe 25 or 50%. If they seem to get anxious, if they don't feel like they're getting enough, or they feel a little fatigued. A couple of the other settings we have to set with the ASV mode is just your PEEP and your FiO2, and then your flow trigger. Most of the time, actually with both the ventilators we use, we don't really have to mess with the flow trigger too much. With the T1, it usually seems to default to -5 centimeters of water pressure. So it is fairly simple for the ASV. The patients are in the ASV mode. It's just a matter of putting in their ideal body weight by setting their height, setting their percentage that you want them to have of their predicted minute volume, and then their PEEP and their FiO2. The APRV, the airway pressure release ventilation, to really oversimplify that, and there's actually going to be a different presentation given by one of our other crew members on this. It's a form of pressure control ventilation with an extreme IE ratio, and it's used to improve oxygenation of an acute lung injury or your ARDS patients. And it does this by increasing the patient's mean airway pressure from the increase in the inspiratory time. So I'm going to have some more slides on the mean airway pressure, and I think it'll make some more sense. But when we talk about an extreme IE ratio, normally you want your expiratory time to be greater than your inspiratory time, and when it's not, it's said to be an inverse IE ratio, and that's something we normally wouldn't do on our own, at least without consulting with somebody, unless maybe we're picking somebody up from an ICU that's already on an inverse IE ratio. So with the APRV, the inspiratory is going to be so reversed. Normally it'd be like a 1 to 2 inspiratory time to expiratory time, or 1 to 3, where in APRV it might actually be like a 8 or 9 inspiratory time compared to an expiratory time of 1 when you do the math. So it might be actually a 9 to 1 IE ratio versus like a 1 to 3. I'll try to explain this a little bit better later on in the presentation. But this isn't something we'd probably make a decision on our own to go to. Maybe if we're picking somebody up that's already on an APRV setting and they're doing well with it, maybe make a quick phone call back here to Lehigh, talk to the attending or the on-call respiratory person, senior respiratory person, and see if everything's good to go. Definitely, if you think you're going to make that switch on your own, you probably want to consult somebody on that. The typical settings, there's really not a whole lot to put on when you select it. You put your P high, which is your high CPAP, and that's going to go up to 20-30 centimeters of water pressure. And then your P low, which is your low CPAP, which is kind of, you can almost equate to your normal PEEP settings. That's going to be somewhere from 0 to 5. And then your T time high, and that's going to be your inspiratory time. And that's going to be 4 to 6 seconds. And your T time low is going to be 0.2 to 0.8 seconds. That's how we get those pretty severe inverse IE ratios. And the rate is determined by the combination of the T high and the T low times. So if you add up your T low time or your T high time, maybe 6 seconds and maybe a half second for your low time, which some people will call your exhalation dump or your dump time, it comes out to like 6.5 seconds. So you just divide that into 60, and now that's actually how you get your respiratory rate for your APRV mode. It's not actually something you dial in specifically. It's the machine kind of figures it out by adding up your high and low times and then dividing it into 60. Your non-invasive positive pressure ventilation modes, you have your CPAP and your BiPAP. And just to kind of keep probably a quick review for most of you, especially since we use CPAP now in the pre-hospital environment, even in the 911 settings, it is similar to PEEP, and it's more for the spontaneously breathing patient who's breathing through a mask, not through an endotracheal tube or a tracheostomy tube or something like that. When we're using our transport ventilator, it needs to be a non-vented mask. And that's where you can kind of get screwed up, because a lot of times for the BiPAP and the CPAP units that's used in emergency rooms, the ICUs, and the hospital, they use a ventilated mask. And if you try to use that mask with our ventilators when using CPAP or BiPAP, it's not going to work. It's going to leak too much, and it can't keep track of your exhale tidal volumes. It's going to keep trying to apnea ventilate the patient. Your machine's not going to be able to keep up with it. So you have to remember to use a non-vented mask, which we do carry in our helicopters and the ambulance if there's none available in the emergency room or the ICU where you're picking up the patient. And obviously that goes the same for the BiPAP. You really need to go through the reference guides for the non-invasive modes for each ventilator to truly know what the differences are, and actually spend some time playing around with the ventilators at the bases. to figure it out. Just some hints when you're using your non-invasive positive pressure ventilation. If you're having a problem with oxygenation, usually increasing your seep or expiratory pressure, and those two terms I'm using interchangeably, will help with your oxygenation. If you're having problems maintaining your CO2 or your end tidal CO2, increasing your inspiratory pressure will help with your ventilation. So if you need to blow off some more CO2, you increase your inspiratory pressure. Just some CPAP hints, and that's when you're using only CPAP, which is pretty unusual unless you're using one of those disposable CPAP setups in the 911 vehicle. But typically in the critical care transport environment, we're going to use BiPAP. But those rare cases when we're only using CPAP, for the LTV 1200 ventilator, we just simply set the machine to SIMV mode, set the rate and volume to 0, and then set PEEP to your desired level of CPAP. So if you want 10 of CPAP, you set your machine to 10, to SIMV mode, set your rate to 0, your volume to 0, and then set your PEEP level to 10. And what happens if your patient does go apneic, your machine will default, I think, to a rate of 10 or 12 to I think a pressure control or a standard volume level for your standard adult patient. For the Hamilton T1, it can be a little confusing if you're going just to it, if you just want to use CPAP and not the BiPAP. So you set your non-invasive ventilation. You set your mode to NIV or NIVST, which is your non-invasive ventilation modes for that machine. You set your expiratory pressure to 0, and then you actually set your inspiratory pressure to your desired level of the CPAP level. So that's something that can be a little screwy. Otherwise, the machine's not going to be able to. It's not going to be able to tell exactly what the patient's doing if you just try to set your inspiratory pressure. Your expiratory pressure to your CPAP level. It's not going to work. It's not going to work right. So the machine actually monitors your pressure, your patient's airway pressures and volumes and everything that goes with it in the CPAP mode by setting your inspiratory pressure. I know that sounds a little opposite, but that's how you're supposed to do it on the Hamilton T1. You have to go through the reference material that's mentioned later in this program for using your non-invasive ventilation for each of our transport ventilators. Your ventilator modes, a little bit more to add on to this, and it'll help lead into some of our strategies when we have to make changes. The more typical settings that we would use, we have to set our tidal volume and our rate, which is just basically the frequency per minute. The volume breath type, and usually, like we mentioned, your volume, we're going to use a volume breath type for our adult population, and the usual tidal volume is 6 to 8 cc's per kilogram of ideal body weight. That doesn't mean the patient weighs 300 pounds and they're 5'5", that we base our ventilator settings on that. We start on 6 to 8 cc's based on their height, which we can plug into the machine, will actually give us our ideal body weight. For our patients with COPD, asthma, ARDS, and acute lung injury, maybe we want to consider just starting at the lower end of that, maybe 6 cc's or 6 milliliters per kilogram of ideal body weight, if we have to increase our rate a little bit, get the ventilation we need. A good place to start most of the time, especially if we're starting on our ventilator with this patient, if they're coming off a bag valve mask right to our vents, maybe 10 to 12 breaths per minute. And then adjust as you need to. To change your arterial CO2, or if you're monitoring your end tidal CO2, which we should be for every ventilated transport or a patient we're transporting, that requires a change in the minute volume. And that's going to be up to you, the one operating a ventilator, whether you want to change your minute volume by changing your rate or by changing your volume, whichever seems a little more out of whack. That's the one you probably want to change. In most cases, we'll put on 5 a peak, maybe a little bit more, maybe a little bit less if there's hemodynamic compromise. But usually most of our patients will start with 5. And then, as we mentioned before, 10 to 5 centimeters of water pressure is the usual range for pressure support. And again, the pressure support's only used in the SIMV mode. You actually can't set it in the assist control or CMV mode because it's going to deliver that full breath anyhow. Our FiO2, that's a level as needed. We want to try to avoid using long-term high concentrations if possible. Just something to keep in mind, if somebody's on 100% FiO2 and they're getting that for as little as 5 to 6 hours, that could start to go, at that little of time, could start to cause some alveolar damage. If we need to do that to maintain a sat in the low 90s, then that's what we need to do. Even if they've already been on it for a longer time at the sending hospital, if that's the only way we can maintain it, along with maybe some of our other strategies for maintaining our oxygenation for the patient, then that's, by all means, that's what we need to do. But if we can drop it down, or if you see that they're already on 60% and their SATs are fine, stick with the 60%, or maybe even go lower, for example. So not all our patients need to be, need 100% oxygen. That's something that's kind of changed over the last few years. If they need it, they need it, but if they don't, try to avoid using it. Your IE ratio, I talked about that a little bit before. It's usually like a 1 to 2 or 1 to 3 is a good place to start for most patients. So on the LTV 1200, for example, we don't actually directly adjust our IE ratio. We actually adjust our inspiratory time, and then we look at the display to see what the IE ratio comes up as. So if we increase our inspiratory time, that's actually going to decrease our IE ratio. If we decrease our inspiratory time, that's actually going to increase our IE ratio. On the Hamilton T1, I believe it's on the SIMV mode, we actually set the inspiratory time, and I believe it's the CMV mode, or which we also refer to as the assist control mode. We directly change the IE time. Either way, it gives you a display right away of what the other is. So if you're changing your inspiratory time on the T1, it'll give you right away your predicted IE ratio. And if you're changing your IE ratio on the Hamilton T1, it'll display right below that setting what your I time's actually going to be then. Some of our strategies for ventilator setting changes. When we're thinking about making changes to the ventilator, I guess you need to look at, do we really need to change them? If we're picking up a patient from somebody else's ER or ICU, and everything's in line just right, their SATs are good, their CO2 is good, whether you're monitoring your end tidal, it was good on their blood gas, their airway pressures, especially their plateau airway pressures, are good. You want to consider why the patient's on the ventilator, what put them on the ventilator, why they're still on the ventilator, their hemodynamic response to the ventilator. Sometimes people drop their blood pressures if their airway pressures are too high. Some patients that might be on the dry side or are having preload problems might not tolerate higher volumes or higher pressures. You also want to consider the metabolic needs, their acid-base balance. If somebody's profoundly acidotic and we try to give them perfect numbers, for example, we're not really doing the patient any favors. In fact, we're probably hurting the patient. The classic example of that is your DKA patient has an end tidal of, let's say, 20, but their pH is around 7.0. If we try to correct their end tidal, we're probably going to make that patient a lot worse and probably harm that patient. So we need to look at the whole patient. And then, we have to look at their ability of the patient to tolerate the current settings. Are they fighting it too much? Are their airway pressures too high? Maybe they're coughing against it too much. Maybe their lungs just aren't in shape for that much volume or that much pressure. But if everything looks good, even if the numbers aren't by the book perfect, but everything else is looking good with the patient, their airway pressures are good, and everything's fine, maybe we don't really need to mess with the settings, especially if their end tidal and their sats are good. On the other hand, there are times we do need to make changes. Sometimes their settings aren't the most appropriate when we pick them up at referring hospitals. Sometimes there's been changes in that patient since the time they called for us, or even since the time we initially put them on the ventilator, whether it was from a scene flight or maybe in a facility that we actually started on our ventilator because they were using a bag valve when we got there. So I kind of cut and paste one of my own cheat sheets that I made up last year onto this part, and this is going to be in our reference material, whether it's on the EMS charts or the reference guides that are going to be coming out program-wide in the next month or so, I believe, from the time we're making this presentation. We started with our low pulse ox, or maybe our low arterial blood gas oxygenation. This might be a little bit hard to see, and probably a little more value if you have it right in front of you. It is on EMS charts right now, and like I said, it's going to be in our resource, or in our as one of our resources. So we're having a problem with maintaining our oxygenation. So of course, the first thing we're going to do, especially in our environment, is we're going to increase the oxygenation. So if that's not working, then where do we go to? And maybe, we do eventually want to turn it down, especially for longer transports. So where else can we go to? So now we talk about increasing our mean airway pressure. So I'm going to jump ahead to our mean airway pressure slides. And maybe the whole concept of the mean airway pressure will give you a little understanding. We'll go back to this slide. So when we think of mean airway pressure, I personally think of oxygenation. Ever since it was explained to me this way some years ago, I've had a much better understanding of how to oxygenate patients that we're having difficulty with. Basically, mean airway pressure is just a combination of pressure and time on your ventilator. So it has to do like with your PEEP, which is there all the time. So it's there 100% of your time. If you have 5 of PEEP on, that pressure of 5 is there all the time. If you just have higher airway pressures during inspiration, like with your pressure control ventilation or whatever pressure you have for your peak inspiratory pressure or your plateau pressure with your given volume, it's only there during the inspiration cycle. So just keep that in mind. So your mean airway pressure, again, is just a combination in some complicated formula of pressure and time during your mechanical ventilation. And when you're increasing mean airway pressure, the functional residual volume is increased. And everybody's probably thinking, oh God, what the hell is FRC? What the hell is functional residual volume or capacity? What does that have to do with mechanical ventilation? Well, just a real quick physiology lesson here, and I'm sure just about all of you have seen this little graph somewhere along the line. Your functional residual capacity is just a combination of your expiratory reserve volume, and that's the amount of air that's left in your lungs, or that you're actually able to blow out when you forcefully blow out. So you would normally exhale, and then you blow out every last bit that you possibly can on your own. Well, that's your expiratory reserve volume, that last part that you're forcefully blowing out. Your residual volume is the amount of air that's left over after you forcefully exhale as much as possible. So your residual volume, the only time you're really going to lose that is maybe when you're suctioning the patient, something to keep in mind down the road. So your FRC is really what's there in your lungs after your normal exhalation. And that's actually where your oxygenation happens. A lot of people think you get oxygenation from squeezing the bag faster, and that's sometimes the case, especially if you went too long in your intubation attempt. But really, oxygenation happens after the person has exhaled, is to pressure the alveoli up against the capillaries. So when we increase our mean airway pressure, we're actually expanding our FRC values, which in turn increases your oxygenation. And the reason this happens is the increase in oxygenation is due to the increased surface area contact between the expanded alveoli and the capillaries surrounding them, allowing for better oxygenation or oxygen diffusion. So your oxygen diffusion into the capillary bed of your lungs from the alveoli is actually happening when the alveoli are pressed up against those capillaries, or if you want to think of the expanded grapes pressed up against those capillaries, or your alveoli. So that's when it's actually happening. So when we talk about mean airway pressure, the more pressure you have and the more time that pressure is there is your mean airway pressure. I hope that makes a little bit of sense. It's very similar to your mean arterial pressures in a way, except that it also factors in time. So when you think of your mean arterial pressures, you're thinking of it's an average, more or less, of your systolic and diastolic blood pressures. Your mean airway pressure is really just an average of your airway pressure over time. I hope that makes a little bit of sense. But when you're thinking of increasing your oxygenation to the patient, those patients that are below 90, you've increased your FiO2 at 100%, and you just can't seem to raise your oxygen saturation, and you're really starting to pull your hair out, maybe following this guide might give you a little insight which way to go. So we're having our patient, we're having a hard time maintaining oxygenation. So we talked about increasing our FiO2 again. We go down here. Usually the first thing we're going to do in most cases, unless they're in extraordinarily high levels of PEEP, is we're going to increase the level of PEEP. Now the only problem with that, or one of the problems with that, is it may decrease the cardiac output. I've mentioned that just a little bit. So that's going to be more patients that are sensitive to a decrease in preload, or the amount that's going into the right side of their heart. So that might be maybe the patients that are a little bit on the dry side, maybe have a little bit of right heart failure. Increasing your PEEP too much on those patients might have a problem with their blood pressure. You may want to, for your patients with a closed head injury or intracranial hemorrhage, where there's too much pressure inside their cranium, we want to keep our PEEP at 5 or below if we can all help it. The reason for that is the PEEP levels above 5 might decrease the venous return back into the thoracic cavity from the head, and there might be some more cerebral edema, there might be some more swelling inside their head. The bleeding that might be going inside their head might not be able to drain off as well. Now the amount of PEEP that you add is also going to add to your airway pressures. It's going to add to your peak inspiratory pressures, and more importantly, it's going to add to your plateau pressures. So you want to keep that in mind. So if you have a patient that already has plateau pressures of, let's say, I'll just use for example, of 35 centimeters of water pressure, and now you're throwing 10 more of PEEP on, well now it's going to be up around 45, and there's a chance you're going to set up that patient for an acute lung injury, or maybe increase their likelihood of developing ARDS if they haven't already. So sometimes you need to trade off, but that's something you want to keep in mind. Another way you can increase your mean airway pressure along with your PEEP, either in addition to your PEEP or maybe in place of your PEEP, is to increase your inspiratory time. And we talked about increasing your inspiratory time. That's increasing the time component of your mean airway pressure. Now, if you're increasing your inspiratory time, that it's past an inverse IE ratio, that means that your inspiratory time is actually longer than your expiratory time. You probably want to talk to somebody about that, especially if the patient's not already there. Maybe picking up from somebody else's ICU. If they're tolerating it that fine, an inverse IE ratio, you might be kind of good to go. You still might want to make a phone call back. But definitely, if you're going to go to that on your own, you probably need to talk to somebody about that. There can be some hemodynamic compromise with that. And with our asthma patients, your COPD patients, someone that's wheezing, showing signs of bronchospasm, we don't really want to go to a reverse IE ratio. In fact, we really like to go increase their IE ratio to where their expiratory time is longer and longer, and it gives them enough time to exhale. So the patients that are possibly in bronchospasm or asthmatic, especially if they're actively in bronchospasm, we have to be careful of those patients that there's not too much air trapping. So when we go to these reverse IE ratios, or maybe even just typically increasing our IE time, we need to watch the patient for an increase in end tidal. Now, if it's just simply an increase in end tidal, but their saturations come up to an acceptable level, maybe we're willing to trade that off for the short term, just to keep the oxygen flowing throughout their body and maybe live with a little bit higher CO2. Now, if there's signs of air trapping or auto PEEP, you see their auto PEEP levels rising, like let's say you have it set to 5 and you notice it won't go below 10 when you're looking at your ventilator, then maybe you need to take a look at what you're doing, and maybe you need to turn your I time back down. You need to see what you're willing to trade off to get your oxygenation. Obviously, you need to keep an eye on your airway pressures all the way around. If there's a big difference between, for example, your peak inspiratory pressures and your plateau pressures, that could be a sign of bronchospasm. Maybe they just need to be suctioned. We'll talk a little bit more about that when we talk about airway pressures. But maybe going to an increased I time isn't going to be your best strategy for that. So, I kind of ask you to kind of go over this little cheat sheet I made up. It's also good to go over even after a call. If you had some problems, look at it afterwards, even if you didn't look at it, right at the time, or maybe on the way out to something. If you're going out for an ARDS patient or a difficult patient if they're having problems ventilating, kind of go through this ahead of time. Anytime we're making ventilator changes, though, you got to monitor the patient's changes, whether it be their airway pressures, their oxygenation, their end tidal, their IE ratios, auto PEEP, and even their hemodynamics, like their blood pressure, their heart rate. So I think I kind of beat that dead horse a little bit as far as oxygenation. We'll go back to our next section. When we're having problems with a high end tidal, or just generally speaking, problems with an end tidal issue, or your CO2 levels via blood gas, is the patient breathing against the ventilator? That's something you want to think about. That's something we want to think about at any time we're having problems ventilating a patient. If they're fighting the ventilator, that's going to make it hard. It's going to make it more difficult with their airway pressures. It may affect their oxygenation if they can't get a full breath in. It can easily affect our CO2 levels. So we want to make sure that the patient has good sedation, analgesia, and sometimes we even need to chemically paralyze these patients. So, if the patient's not breathing against it, and we want to increase our minute ventilation, so we can do that by increasing our rate or our volume. So as far as changing, you might want to consider changing the rate if their inspiratory pressures are already high. So if you have somebody that has especially a plateau pressure that's high, but you need to increase their minute volume, you might want to go to the rate. Now, if their peak inspiratory or plateau pressures are relatively low, like around 20 or lower, maybe 25 or lower, and maybe it seems like the tidal volume is a little bit on the low side, then it might be just easier just to switch them over, just to increase their tidal volume, or if you're using pressure control ventilation, then increase the amount of pressure you're delivering for each breath. So conversely, if you're having problems with a low end tidal, CO2 or a CO2 via an arterial blood gas, we don't necessarily want to correct those, especially real quick. We want to think about those before we correct them. So the first thing we want to think of if their end tidal is low is the patient compensating. We talked about the DKA patient, the severe diabetic patient, other forms of severe acidosis. So especially if you have a blood gas and a pH that can document a low pH level on a gas, then we probably don't want to correct the low end tidal, at least all the way. If we just suspect, even if we don't have a blood gas, maybe one just wasn't drawn. Maybe this is a scene mission. Maybe, if everything, the patient's real shocky, we suspect they're DKA, we suspect they're really acidic. Maybe we want to go on the low side for maintaining a lower end tidal. Maybe the patient's just too awake. So again, if we're pretty well convinced that their pH is close to normal, but they're wide awake and they're just really breathing really fast because they're agitated or whatever, then maybe we need to sedate them. Maybe not be real quick to chemically paralyze them, but maybe sedate them, see how they do with that. If our end tidal really still seems low, we want to bring down their minute volume some. Double check: is their tidal volume is it equal to or greater than 6 to 8 milliliters of ideal body weight? If somebody has them set up at a referring hospital and they're getting 10 to 12 per ideal body weight at a rate of 15 or 20, then you probably want to consider probably decreasing both, or at least your volumes. And again, anytime we're making changes to our ventilator, we need to look at the patient. We need to look at their airway pressures, their end tidal. We want to make sure we didn't do anything too funky with their IE ratios. We want to check for auto-PEEP. We want to check their blood pressure, make sure it's okay. We want to check their oxygen saturation. So that goes with any time we're making changes to the ventilator. This looks like a pretty busy slide. So now we're talking about higher than desired inspiratory pressures, especially with your plateau pressures. Sometimes just elevating the head of the bed can make a big difference. Maybe not all trauma patients we can do that. Most neuro patients we can, especially if they're on the ventilator. Now, if it is, depending on the type of stroke, maybe we want to leave the head flat. Maybe if they're hemodynamic support, we might want to leave the head of the bed flat. But if we have, especially like our more oversized patient, and they're flat, and they're a standard medical patient on the ventilator, or their C-spine's been pretty well cleared, they're not on a backboard, it's probably best we, excuse me, elevate the head of their bed. It'll help lower their airway pressures. It also helps with their whole drainage and secretions, and might help reduce the risk of a ventilator-acquired pneumonia also. I think the patient will just tolerate it better. If you could just imagine a 350-pound patient being mechanically ventilated, being completely supine in the bed or on a stretcher, all that pressure that's up against the diaphragm, of course it's going to increase our airway pressures. So, now we look at a couple other things. To start with, is our plateau pressure elevated? If it's not, we have high peak inspiratory pressures, but the plateau pressure is not elevated, then there's probably an airway resistance problem. And those problems we can often correct fairly easy. Might be from excessive secretions. So you suction your ET tube, see if there's anything there. See if that brings down your peak inspiratory pressures. Your plateau pressure will probably stay pretty much the same after you correct the resistance problem. Is there any signs of bronchospasm or wheezing? If there is, i.e. with your normal, relatively normal plateau pressure, or even just a significantly lower plateau pressure than your peak inspiratory pressure, You want to consider, after maybe you suction ET tube, maybe giving a bronchodilator. So maybe you want to give some albuterol, maybe you want to give a duoneb. Maybe your ET tube or your trach tube is relatively small diameter. Maybe there's something going on and there's only a 6L endotracheal tube in a standard adult patient. Well, of course, there's going to be a difference between your plateau pressures and your peak inspiratory pressures. And that's something we're probably not going to do in our environment. We're not going to correct that in our environment, but just something to be aware of. So if you see your peak inspiratory pressures are high and they have a small endotracheal tube, for example, you check your plateau pressure, and that's pretty close to normal. We're probably not going to mess around with changing an endotracheal tube in the transport environment. Leave that for the ICU, whoever's receiving the patient when in a more controlled environment. Just a little bit of information on plateau pressures. When we talk about plateau pressures, on the 1200 you actually have to manually get it, and that's something you'll have to kind of learn on the machine by doing an inspiratory hold, and then the machine will give you the reading. On the Hamilton T1, you can just go to the third diagnostic screen, and it'll give you a constant plateau pressure. And essentially, in the very simplest form, a plateau pressure is the pressure at the alveoli when there's no air movement. It's pretty much that simple. So that's the pressure that's actually at the alveoli, but the machine needs to kind of measure it when there's not much movement going on. So we talked about our plateau pressure. So if it's not elevated when our peak inspiratory pressures are high, it's usually a resistance problem. If it is elevated, our plateau pressures, then it's a compliance problem. So when you think of a compliance problem, that means it's kind of hard to squeeze a bag valve, for example, when you have a compliance problem with your patient. So for example, if you're ventilating your patient with your bag valve mask or just your bag valve via endotracheal tube and it's hard to squeeze, I always think of that like a compliance issue, if you can kind of visualize that. So what can cause compliance issues? Something correctable, gastric distension. Consider an OG tube. So in our environment, especially when we're flying a patient, we always want to make sure when they have the OG tubes that at the very least it's open air as we're flying, especially at altitude, like more than a few thousand, a couple of few thousand feet. That's something you might see as a test question in some of your certification exams. Maybe hook it up to suction. This is especially important, your gastric distension with an infant or a child. Any child or infant that's intubated on mechanical ventilation, chances are they got a pretty fair amount of air in their gut, maybe some other secretions, especially near drowning. But regardless, they need to have an OG tube almost immediately after the intubation. The adult, you can kind of probably use a little bit of judgment. Maybe that's something that can wait till you're in the aircraft. But for the infant or the small child especially, probably want to have an OG tube following right away the endotracheal tube. Your CHF, your pneumonia, your infiltrates, your infusions, your pleural effusions, that's going to be more of a compliance issue. The only way we're going to really get around that is considering lowering your tidal volumes and increasing your PEEP. That might help actually treat the underlying conditions, re-expand your lung a little bit without really overinflating. Your tension pneumo, if you're having high airway pressures as regards to your tension pneumo, and you're going to be looking at other things, your hemodynamics, your oxygenation, but you're pretty much convinced you have a tension pneumothorax. Obviously that calls for an emergent needle decompression. And eventually a chest tube when that's practical. Your ARDS, your acute lung injury, you could consider lowering your tidal volume. We talked about using 6, maybe even a little bit less, and help overcome with your oxygenation problems when you do that. Maybe increase your PEEP some. Hyperinflation can cause compliance issues. So you want to make sure your patient has enough time to exhale, which means their IE ratio has to be good. So if they're not having enough time to exhale on a 1 to 2 IU ratio, maybe you need to expand that to a 1 to 3 or a 1 to 4 IU ratio, which means you're going to have to decrease your inspiratory time. Some of your more generic problems, when there's a compliance issue, it's maybe your tidal volume's just set too high. That happens sometimes. Sometimes it happens at some of the referring places we go to. They just have their volumes way too high. They might be set to 10 to 12 per ideal body weight. Maybe they set it to their actual body weight. So just evaluate where you're at for your tidal volumes. And as usual, anytime you're making changes to your ventilator, of course we want to look at our patient, your end tidal, your oxygenation, make sure they're not auto-peeping. You want to check their hemodynamics. You want to check their blood pressure. You want to check their airway pressures. Anytime you're making changes. And you need to reevaluate that, be careful to reevaluate that, and continue to reevaluate that during your trip. Things change. Especially when moving patients around, especially in our environment. Things do change with these ventilator patients. Some specific transport ventilator resources for the T1. You can probably Google this if you don't have it right in front of you. You go to college, Hamilton/medical.com. They have some non-CE learning, which is a good place to start. Ventilator system concepts, long ventilation, both natural and ventilation, essential variables, and mechanical breath types. So those are 3 little mini courses right there. Each have a little quiz, but you don't actually get any CE credit for those 3 courses. And then to get some CE, which our department educator might kind of push on everybody. I think we all did this about a year or 2 ago, and it might be time to kind of redo it again for everybody. There's the Hamilton T1 Part 1, Hamilton T1 Part 2. There's a section, little course on adaptive support ventilation, the ASV that we talked about. And there's even an online and downloadable T1 simulator. That kind of helps give you a feel of what happens when you change some of the controls on the ventilator, especially for the things that are a little bit less than the normal. And those 3 courses there, you actually do get CE for it. There's quizzes, and you can print off a certificate and send it into the department educator. That's obviously going to be up to MedEvac education and management, assigning those courses. For step-by-step instructions, I did a PowerPoint on this a couple of years ago, and I updated it a couple times since then. It's actually been more than a few years ago on the LTV 1200. You can go to EMS charts. It's on there. If you just sign on the EMS charts and then click on the link below, or you can just find it in the Human Resources section under the document warehouse that we have. If our program moves away from EMS charts, we're going to have a document warehouse somewhere. So in case you're viewing this when EMS charts possibly might go away by then, it'll be in our document warehouse for MedEvac. Some specifics about the ventilators themselves that aren't really in the manual. This is a kind of, but you don't realize the impact of it sometimes. The LTV 1200 tends to use a lot of gas, and it can use up to 10 liters per minute of your source gas just to run itself. So this is 10 liters a minute. That's not even going to the patient. So if you can imagine, the amount, your liter flow might be, 25, 30, 40 liters per minute just going to the patient, and then you add another 10, you can imagine how fast you're going to go through an E-cylinder, or maybe your lock system on the aircraft. The 1200 doesn't tend to work real well in the lock system on the aircraft if it's below 2, for example, a reading of 2 on the locks. Many home and extended care ventilators use an earlier version or a slightly less version of the LTV 1200. You might see them out there. They're the 950s to 1000s, the LTV model. And you may be asked to transport some of these patients, especially back to their homes sometimes, to LTAC units, to nursing homes. Excuse me. And they operate very similar. And if they're patient, and you have these patients and they're already on it and they're tolerating it well, especially if they're going back to a non-acute care setting, by all means, take them back on this. They'll probably be more comfortable. The family will be more comfortable if you just use that ventilator. And they might actually be on that ventilator while they're in our ICU or even our PICU. Some of the only real differences is maybe on these slightly less LTV models, like the 950s, 1000s, I think there's even a 1100 out there, maybe even a 900. They don't really dial in an FiO2. They actually just flow in, maybe 1 liter or 2 liter, 3 liters per minute of oxygen. And that's usually well known before, as you're picking up the patient. And they also have external PEEP valves, so you won't actually dial that in on the machine itself. There'll actually be a valve at the end of the exhalation valve where we actually manually dial it in. But that'll usually be done before you get there, but just something to be aware of. The 1200 LTV 1200 can have problems ventilating small children and infants when using volume type breaths. So if you're trying to deliver a tidal volume, a preset tidal volume to a small child or an infant, even when you're using the right size tubing, you're probably going to have a problem with that. The reason is the tubing will actually expand as the machine is trying to deliver the breath. And that volume of maybe 50 or 60 or 100 cc's is actually getting lost in that tubing expansion. And the machine has a hard time sorting all that out. At least that's the way I see it, and that's as simple as I can explain it. So actually switching your patient to pressure control ventilation will usually solve that compliance problem. So if you're having problems, you switch your let's say an infant over to your LTV 1200 and you're trying to volume and their end titles go through the roof and their sats start to drop, well, obviously get them back on a bag valve, ventilate them back up, get your ventilator set to a pressure control setting, see what their peak inspiratory and their plateau pressures were at the referring facility. If they're around 20, start your pressure control ventilation around 20, maybe a little bit less, a little bit more, but right around 20. See what type of volumes you get, hook it up to the patient, and see how you do. You'll probably do pretty well with it. The machine is rated to go down to 5 kilograms of ideal body weight. I'll tell you, there's been cases that we've picked up from referring facilities and that I've actually physically seen in our PICU where there's been 2.5, 3 kilogram infants on these ventilators in the pressure control mode, even long-term infants that go back to, sadly, nursing homes for infants on ventilators on the 1200 or even the 1000s at a much lower weight than the 5 kilograms that it's rated for, and they do absolutely fine on it. I'm not saying we should necessarily be doing that, but it's out there. Conversely, the Hamilton T1, I'm not doing a commercial or necessarily promoting the T1. Each ventilator has their advantages and disadvantages. Does not seem to waste as much gas as the 1200 does. It's not using much gas just to run itself. Most of the gas it's using is going to the patient. The T1 seems to be more comfortable and better tolerated by most patients. It has more lung protective features. But you as the operator need to be more aware how these functions may affect the patient when initially placed on the T1 ventilator. Now you're probably asking, how the hell would I know that the T1 ventilator is more comfortable? Well, subjectively I see that the patients seem to tolerate it better. Objectively, as I can get, kind of a practice I started back in the service when we had new ventilators or ventilators we weren't familiar with. I actually hooked up a piece of practice tubing, put the same exact settings in, maybe for volume ventilation, same inspiratory time, same alarm limits, same everything. Hooked up a rather large endotracheal tube, cut it off, and actually just orally ventilated myself just to see what the difference was between the machines. And I could see that on the T1, it got the same amount of volume in that felt more comfortable, and also at lower airway pressures. So the T1 does have some more technology than the 1200. So side by side on the same patient or person, i.e. me, it actually did ventilate me with the same volumes at a much lesser pressure, and it did feel more comfortable. So objectively, that's how I can kind of tell it seems more comfortable for the patient. And presumably more safe since it's at a lower airway pressure. Now, because of these protective features of the T1, it does take a couple minutes to deliver that set tidal volume. Like, let's say we're giving volume type breaths. So initially, when we switch the patient over from another ventilator or even from a bag valve mask to our transport ventilator, and it's the T1, there's probably, more likely than not, going to be a transient change in the end tidal and the SpO2. So what's going on if you watch your volumes? Let's say it's set to 500. You set your patient for 500. For the first minute or two, you're going to see a volume of about 180, then maybe 220, then maybe 250, then maybe 300, then 350, then 400. So the machine's trying to figure out the most efficient and what it feels the safest way to deliver those breaths to the patient. Unfortunately, if you're not expecting that, it can freak you out a little bit, especially if the patient's kind of on the edge a little bit and they're pretty sick. You may see a transient decrease in their saturation, and you may see a transient increase in their end tidal. Just something to be aware of. You may try to ride it out. You may try to go back to a bag valve and maybe increase your settings a little bit, at least initially. Also, what goes on with the T1, which I don't have on the slide here, is the alarms are kind of funny as far as when it starts to cut off tidal volumes. On the T1, once it starts to get within 10 centimeters, the peak inspiratory pressure within 10 centimeters of your high airway alarm pressures, it starts to limit the breaths or the amount of volume it's delivering. So if you have a volume set to 500 that you want to deliver to the patient, but when the ventilator reaches 300 milliliters for that breath, and it gets to a pressure that's within 10 of your high pressure alarm, it's going to cut that breath off. So now that's going to be another case where your end tidal is going to start to rise and your sat's going to go down, even though the machine's trying to deliver a full breath, but it won't because it comes within 10 of your high pressure alarm. So just a word of warning, if your patient has some relatively high airway pressures, or even when you're moving the patient around, or maybe the patient's coughing a little bit here and there, you might want to widen out your alarms a little bit. The alarms are pretty sensitive on the Hamilton T1s, so it's just something you need to be aware of. And actually on the 1200s, as long as you're not high pressure alarming, that patient's going to get what you set to deliver, unless they actually hit their alarms. This presentation is not meant to be used as a protocol. It's just one of the learning resources and the tools on the subject. The educational and operational resources from the manufacturer and LVH MedEvac program will change from time to time and require periodic review. So this is something we should be looking at every year at the very least. And by each crew member who's going to be tasked with taking care of the mechanically ventilated patients. And along with that, you go out to the aircraft, you go to the ambulance, you take the test along out there. You go ahead and play with it a little bit. You understand that the alarms are touchy on one versus the other. The 1200, the LTV 1200 is a backup ventilator. When you have it, you know it's in the aircraft, you know it's in the ambulance. Maybe at the start of your shift after you get your normal daily stuff done, maybe it's a good time to go out, take your practice set of tubing that you have at each base and your test along, and go out and play with it a little bit. So that's pretty much it for transport ventilation here at Lehigh Valley MedEvac. Thank you.